Marburg virus disease, MVD, formerly Marburg hemorrhagic fever, MHF, is a viral hemorrhagic fever in human and non-human primates caused by either of the two Marburg viruses, Marburg virus, MARV, and Ravn virus, RAVV. Its clinical symptoms are very similar to those of Ebola virus disease, EVD. Egyptian fruit bats are believed to be the normal carrier in nature, and Marburg virus RNA has been isolated from them. Signs and symptoms. The most detailed study on the frequency, onset, and duration of MVD clinical signs and symptoms was performed during the 1998 to 2000 mixed MARV/RAVV disease outbreak. A skin rash, red or purple spots, e.g. petechiae or purpura, bruises, and hematomas, especially around needle injection sites, are typical hemorrhagic manifestations. However, contrary to popular belief, hemorrhage does not lead to hypovolemia and is not the cause of death. Total blood loss is minimal except during labor. Instead, death occurs due to multiple organ dysfunction syndrome, MODS, due to fluid redistribution, hypotension, disseminated intravascular coagulation, and focal tissue necroses. Clinical phases of Marburg hemorrhagic fever's presentation are described below. Note that phases overlap due to variability between cases. 1. Incubation, 2 to 21 days, averaging 5 to 9 days. 2. Generalization phase, day 1 up to day 5 from the onset of clinical symptoms. MHF presents with a high fever 104 degrees Fahrenheit, 40 C, and a sudden, severe headache, with accompanying chills, fatigue, nausea, vomiting, diarrhea, pharyngitis, maculopapular rash, abdominal pain, conjunctivitis, and malaise. 3. Early organ phase, day 5 up to day 13. Symptoms include prostration, dyspnea, edema, conjunctival injection, viral exanthema, and CNS symptoms, including encephalitis, confusion, delirium, apathy, and aggression. Hemorrhagic symptoms typically occur late and herald the end of the early organ phase, leading either to eventual recovery or worsening and death. Symptoms include bloody stools, ecchymosis, blood leakage from venipuncture sites, mucosal and visceral hemorrhaging, and possibly hematmesis. 4. Late organ phase, day 13 up to day 21 plus. Symptoms bifurcate into two constellations for survivors and fatal cases. Survivors will enter a convalescence phase, experiencing myalgia, fibromyalgia, hepatitis, asthenia, ocular symptoms, and psychosis. Fatal cases continue to deteriorate, experiencing continued fever, obtundation, coma, convulsions, diffuse coagulopathy, metabolic disturbances, shock, and death, with death typically occurring between days 8 and 16. Causes. MVD is caused by two viruses, Marburg virus, MARV, and Ravn virus, RAVV, family Filoviridae. Marburg viruses are endemic in arid woodlands of equatorial Africa. Most Marburg virus infections were repeatedly associated with people visiting natural caves or working in mines. In 2009, the successful isolation of infectious MARV and RAVV was reported from healthy Egyptian fruit bat caught in caves. This isolation strongly suggests that Old World fruit bats are involved in the natural maintenance of Marburg viruses and that visiting bat-infested caves is a risk factor for acquiring Marburg virus infections. Further studies are necessary to establish whether Egyptian rousettes are the actual hosts of MARV and RAVV or whether they get infected via contact with another animal and therefore serve only as intermediate hosts. Another risk factor is contact with non-human primates, although only one outbreak of MVD, in 1967, was due to contact with infected monkeys. Contrary to Ebola virus disease, EVD, which has been associated with heavy rains after long periods of dry weather, triggering factors for spillover of Marburg viruses into the human population have not yet been described. Transmission. The details of the initial transmission of MVD to humans remain incompletely understood. Transmission most likely occurs from Egyptian fruit bats or another natural host, such as non-human primates, or through the consumption of bush meat, but the specific routes and body fluids involved are unknown. Human-to-human transmission of MVD occurs through direct contact with infected bodily fluids such as blood. Transmission events are relatively rare. There have been only 11 recorded outbreaks of MARV between 1975 and 2011, with one event involving both MARV and RAVV. Diagnosis: MVD is clinically indistinguishable from Ebola virus disease, EVD, and it can also easily be confused with many other diseases prevalent in equatorial Africa, such as other viral hemorrhagic fevers, falciparum malaria, typhoid fever, shigellosis, rickettsial diseases such as typhus, cholera, gram-negative sepsis, borreliosis such as relapsing fever or EHEC enterithes. Other infectious diseases that ought to be included in the differential diagnosis include leptospirosis, scrub typhus, plague, Q fever, candidiasis, histoplasmosis, trypanosomiasis, visceral leishmaniasis, hemorrhagic smallpox, measles, and fulminant viral hepatitis. Non-infectious diseases that can be confused with MVD are acute promyelocytic leukemia, hemolytic uremic syndrome, snake envenomation, clotting factor deficiencies/platelet disorders, thrombotic thrombocytopenic purpura, hereditary hemorrhagic telangiectasia, Kawasaki disease, and even warfarin intoxication. The most important indicator that may lead to the suspicion of MVD at clinical examination is the medical history of the patient, in particular the travel and occupational history, which countries and caves were visited, and the patient's exposure to wildlife, exposure to bats or bat excrements. MVD can be confirmed by isolation of Marburg viruses from or by detection of Marburg virus antigen or genomic or subgenomic RNAs in patient blood or serum samples during the acute phase of MVD. Marburg virus isolation is usually performed by inoculation of Grivet kidney epithelial Vero E6 or Ma104 cell cultures or by inoculation of human adrenal carcinoma SW13 cells, all of which react to infection with characteristic cytopathic effects. Filovirions can easily be visualized and identified in cell culture by electron microscopy due to their unique filamentous shapes, but electron microscopy cannot differentiate the various filoviruses alone despite some overall length differences. Immunofluorescence assays are used to confirm Marburg virus presence in cell cultures. During an outbreak, virus isolation and electron microscopy are most often not feasible options. The most common diagnostic methods are therefore RT-PCR in conjunction with antigen capture ELISA, which can be performed in field or mobile hospitals and laboratories. Indirect immunofluorescence assays, IFAs, are not used for diagnosis of MVD in the field anymore. Marburg virus disease, MVD, is the official name listed in the World Health Organization's International Statistical Classification of Diseases and Related Health Problems 10, ICD-10, for the human disease caused by any of the two Marburg viruses Marburg virus, MARV, and Ravn virus, RAVV. In the scientific literature, Marburg hemorrhagic fever, MHF, is often used as an unofficial alternative name for the same disease. Both disease names are derived from the German city Marburg, where MARV was first discovered. Prevention. There are currently no Food and Drug Administration approved vaccines for the prevention of MVD. Many candidate vaccines have been developed and tested in various animal models. Of those, the most promising ones are DNA vaccines or based on Venezuelan equine encephalitis virus replace Icons vesicular stomatitis indiana virus, VSIV, or filovirus-like particles, VLPs, as all of these candidates could protect non-human primates from Marburg virus-induced disease. DNA vaccines have entered clinical trials. Marburg viruses are highly infectious, but not very contagious. They do not get transmitted by aerosol during natural MVD outbreaks. Due to the absence of an approved vaccine, prevention of MVD therefore relies predominantly on quarantine of confirmed or high probability cases, proper personal protective equipment, and sterilization and disinfection. Endemic zones. The natural maintenance hosts of Marburg viruses remain to be identified unequivocally. However, The isolation of both MARV and RAVV from bats and the association of several MVD outbreaks with bat-infested mines or caves strongly suggests that bats are involved in Marburg virus transmission to humans. Avoidance of contact with bats and abstaining from visits to caves is highly recommended, but may not be possible for those working in mines or people dependent on bats as a food source. During outbreaks. Since Marburg viruses are not spread via aerosol, the most straightforward prevention method during MVD outbreaks is to avoid direct, skin-to-skin, contact with patients, their excretions and body fluids, and any possibly contaminated materials and utensils. Patients should be isolated, but still are safe to be visited by family members. Medical staff should be trained in and apply strict barrier nursing techniques, disposable face mask, gloves, goggles, and a gown at all times. Traditional burial rituals, especially those requiring embalming of bodies, should be discouraged or modified, ideally with the help of local traditional healers. In the laboratory, Marburg viruses are World Health Organization risk group 4 pathogens, requiring biosafety level 4 equivalent containment. Laboratory researchers have to be properly trained in BSL-4 practices and wear proper personal protective equipment. Treatment. There is currently no effective Marburg virus-specific therapy for MVD. Treatment is primarily supportive in nature and includes minimizing invasive procedures, balancing fluids and electrolytes to counter dehydration, administration of anticoagulants early in infection to prevent or control disseminated intravascular coagulation, administration of procoagulants late in infection to control hemorrhaging, maintaining oxygen levels, pain management, and administration of antibiotics or antifungals to treat secondary infections. Prognosis. Although supportive care can improve survival chances, Marburg virus disease is fatal in the majority of cases. As of 2023, the case fatality rate was assessed to be 61.9%. The WHO identifies Marburg virus disease as having pandemic potential. MVD was first documented in 1967, when 31 people became ill in the German towns of Marburg and Frankfurt am Main, and in Belgrade, Yugoslavia. The outbreak involved 25 primary MARV infections and 7 deaths, and 6 non-lethal secondary cases. The outbreak was traced to infected grivets, species Chlorocebus ethiops, imported from an undisclosed location in Uganda and used in developing poliomyelitis vaccines. The monkeys were received by Behring Werke, a Marburg company founded by the first winner of the Nobel Prize in Medicine, Emil von Behring. The company, which at the time was owned by Hoechst, was originally set up to develop sera against tetanus and diphtheria. Primary infections occurred in Behring Werke laboratory staff while working with grivet tissues or tissue cultures without adequate personal protective equipment. Secondary cases involved 2 physicians, a nurse, a post-mortem attendant, and the wife of a veterinarian. All secondary cases had direct contact, usually involving blood, with a primary case. Both physicians became infected through accidental skin pricks when drawing blood from patients. In 1975, an Australian tourist became infected with MARV in Rhodesia, today Zimbabwe. He died in a hospital in Johannesburg, South Africa. His girlfriend and an attending nurse were subsequently infected with MVD, but survived. A case of MARV infection occurred in 1980 in Kenya. A French man, who worked as an electrical engineer in a sugar factory in Nzoia, close to Bungoma, at the base of Mount Elgon, which contains Kidam Cave, became infected by unknown means and died on January 15 shortly after admission to Nairobi Hospital. The attending physician contracted MVD, but survived. 71. A popular science account of these cases can be found in Richard Preston's book The Hot Zone. The French man is referred to under the pseudonym Charles Monet, whereas the physician is identified under his real name, Shem Muzok. In 1987, a single lethal case of RAVV infection occurred in a 15-year-old Danish boy, who spent his vacation in Kisumu, Kenya. He had visited Kidam Cave on Mount Elgon prior to traveling to Mombasa, where he developed clinical signs of infection. The boy died after transfer to Nairobi Hospital. A popular science account of this case can be found in Richard Preston's book The Hot Zone. The boy is referred to under the pseudonym Peter Cardinal. In 1988, researcher Nikolai Ustinov infected himself lethally with MARV after accidentally pricking himself with a syringe used for inoculation of guinea pigs. The accident occurred at the Scientific Production Association Vector, today the State Research Center of Virology and Biotechnology Vector, in Koltsovo, USSR, today Russia. Very little information is publicly available about this MVD case because Ustinov's experiments were classified. A popular science account of this case can be found in Ken Alibek's book Biohazard. Another laboratory accident occurred at the Scientific Production Association Vector, today the State Research Center of Virology and Biotechnology Vector, in Koltsovo, USSR, when a scientist contracted MARV by unknown means. A major MVD outbreak occurred among illegal gold miners around Goro-Urmwa mine in Durba and Watsa, Democratic Republic of Congo from 1998 to 2000, when co-circulating MARV and RAVV caused 154 cases of MVD and 128 deaths. The outbreak ended with the flooding of the mine. In early 2005, the World Health Organization, WHO, began investigating an outbreak of viral hemorrhagic fever in Angola, which was centered in the northeastern Uige province but also affected many other provinces. The Angolan government had to ask for international assistance, as there were only approximately 1,200 doctors in the entire country and provinces that had few as two. Healthcare workers also complained about a shortage of basic personal protective equipment. Médecins Sans Frontières, MSF, reported that when their team arrived at the provincial hospital at the center of the outbreak, they found it operating without water and electricity. Contact tracing was complicated by the fact that the country's roads and other infrastructure were devastated after nearly 3 decades of civil war and the countryside remained littered with landmines. Americo Boavita Hospital in the Angolan capital, Luanda, set up a special isolation ward to treat patients from the countryside. Due to the high fatality rate of MVD, some people came to be suspicious of and hostile towards hospitals and medical workers. For instance, a specially equipped isolation ward at the provincial hospital in Uige was reported to be empty during much of the epidemic, even though the facility was at the center of the outbreak. WHO was forced to implement what it described as a harm reduction strategy by distributing disinfectants to affected families who refused hospital care. Of the 252 people who contracted MVD, 227 died. In 2007, 4 miners became infected with Marburg viruses in Kamwenje district, Uganda. The first case, a 29-year-old man, became symptomatic on July 4, 2007, was admitted to a hospital on July 7, and died on July 13. Contact tracing revealed that the man had had prolonged close contact with 2 colleagues, a 22-year-old man and a 23-year-old man, who experienced clinical signs of infection before his disease onset. Both men had been admitted to hospitals in June and survived their infections, which were proven to be due to MARV. A fourth, 25-year-old man, developed MVD clinical signs in September and was shown to be infected with RAVV. He also survived the infection. On July 10, 2008, the Netherlands National Institute for Public Health and the Environment reported that a 41-year-old Dutch woman, who had visited Python Cave in Maramagambo Forest during her holiday in Uganda, had MVD due to MARV infection, and had been admitted to a hospital in the Netherlands. The woman died under treatment in the Leiden University Medical Center in Leiden on July 11. The Ugandan Ministry of Health closed the cave after this case. On January 9 of that year, an infectious diseases physician notified the Colorado Department of Public Health and the Environment that a 44-year-old American woman who had returned from Uganda had been hospitalized with a fever of unknown origin. At the time, serologic testing was negative for viral hemorrhagic fever. She was discharged on January 19, 2008. After the death of the Dutch patient and the discovery that the American woman had visited Python Cave, Further testing confirmed the patient demonstrated MARV antibodies and RNA. In October 2017, an outbreak of Marburg virus disease was detected in Queen District, eastern Uganda. All 3 initial cases, belonging to one family, 2 brothers and 1 sister, had died by November 3. The 4th case, a healthcare worker, developed symptoms on November 4 and was admitted to a hospital. The first confirmed case traveled to Kenya before the death. A close contact of the second confirmed case traveled to Kampala. It is reported that several hundred people may have been exposed to infection. In August 2021, 2 months after the re-emergent Ebola epidemic in the Gwekdu prefecture was declared over, a case of the Marburg disease was confirmed by health authorities through laboratory analysis. 54 other potential case of the disease in a contact awaits official results. This was the first case of the Marburg hemorrhagic fever confirmed to happen in West Africa. The case of Marburg also has been identified in Gwekdu. During the outbreak, a total of 1 confirmed case, who died, CFR equals 100%, and 173 contacts were identified, including 14 high-risk contacts based on exposure. Among them, 172 were followed for a period of 21 days, of which none developed symptoms. 1 high-risk contact was lost to follow-up. Sequencing of an isolate from the Guinean patient showed that this outbreak was caused by the Angola-like Marburg virus. A colony of Egyptian rousette bats, reservoir host of Marburg virus, was found in close proximity, 4.5 kilometers, to the village, where the Marburg virus disease outbreak emerged in 2021. 2 sampled fruit bats from this colony were PCR positive on the Marburg virus. In July 2022, preliminary analysis of samples taken from 2 patients, both deceased, in Ghana indicated the cases were positive for Marburg. However, per standard procedure, the samples were sent to the Pasteur Institute of Dakar for confirmation. On July 17, 2022, the 2 cases were confirmed by Ghana, which caused the country to declare a Marburg virus disease outbreak. An additional case was identified, bringing the total to 3. A disease outbreak was first reported in Equatorial Guinea on February 7, 2023, and on February 13, 2023, it was identified as being Marburg virus disease. It was the first time the disease was detected in the country. Neighboring Cameroon detected 2 suspected cases of Marburg virus disease on February 13, 2023, but they were later ruled out. On February 25, a suspected case of Marburg was reported in the Spanish city of Valencia, however this case was subsequently discounted. As of April 4, 2023, there were 14 confirmed cases and 28 suspected cases, including 10 confirmed deaths from the disease in Equatorial Guinea. On June 8, 2023, the World Health Organization declared the outbreak over. In total, 17 laboratory-confirmed cases and 12 deaths were recorded. All the 23 probable cases reportedly died. 4 patients recovered from the virus and have been enrolled in a survivors program to receive psychosocial and other post-recovery support. A Marburg virus disease outbreak in Tanzania was first reported on March 21, 2023 by the Ministry of Health of Tanzania. This was the first time that Tanzania had reported an outbreak of the disease. On June 2, 2023, Tanzania declared the outbreak over. There were 9 total infections, resulting in 6 total deaths. On September 27, 2024, an outbreak of the Marburg virus was confirmed in Rwanda. As of September 29, 2024, 6 deaths and 20 cases had been confirmed. The Rwandan Minister of Health, Sabin Nsanzimana, confirmed that the infected were mostly healthcare workers. He also confirmed that contact tracing efforts had already been initiated in the country. Experimentally, recombinant vesicular stomatitis indiana virus, VSIV, expressing the glycoprotein of MARV has been used successfully in non-human primate models as post-exposure prophylaxis. A vaccine candidate has been effective in non-human primates. Experimental therapeutic regimens relying on antisense technology have shown promise, with phosphorodiamidate morpholino oligomers, PMOs, targeting the MARV genome. New therapies from Sarepta and Tecmara have also been successfully used in humans as well as primates. Rwanda is currently experiencing its first ever outbreak of Marburg virus disease, MVD. The outbreak was first reported to the World Health Organization on September 28, 2024. The U.S. Embassy in Rwanda has issued an alert on the matter. The Marburg virus was first discovered in 1967 after outbreaks in Marburg and Frankfurt, Germany. These outbreaks had been linked to lab work involving African green monkeys from Uganda. Thank you for watching this video.